Good morning, everyone, and welcome to our monthly ABIN webinar. We're so glad you're joining us bright and early. We know with the time change, it might feel earlier for some of you. Please put your name and the organization that you're with in the chat. That would be great. We always want to know who's on the call with us. I'm just going to give a quick introduction. I'm Kim Schuler, and I'm so glad that you're joining us this morning. I want to remind everyone that this recording or this webinar is being recorded, and we will be posting this on the ABIN website. We will also have these slides up and available. So please feel free to reference those as needed and know that you are being recorded and this will be put on our website. Um, as we're getting started this morning, I also want to give a shout out to Caitlin Johnson. Caitlin, thank you so much for all your work that you have been doing with the students and for your work getting our presentation up and ready this morning. So I appreciate that. Today we have the MSW intern students with us. The MSW students have been working all year in different primary care clinics across the state. And so we are featuring them today. They're going to be talking about their experience, things that they've learned, any challenges and opportunities on things we can do to improve this. And we also have Dr. Lofton with us from Lofton Family Clinic, and we're going to be featuring him, and he's going to be sharing a little bit about his experience on what it's been like to have one of these students in a primary care clinic. So we're really excited that we're bringing this information today. And now we're going to talk to you just a quick level set. I know we focus a lot on integrated behavioral health, and what that can look like. And so for the purposes of today, we just want to level set and remind everyone integrated behavioral health means that primary care and behavioral health clinicians are working together with patients and families. This is a whole person model, and it is a core function of the advanced patient-centered medical home, with primary care clinicians and behavioral health clinicians working together in the same space. They're addressing mental health issues, substance abuse issues, health behaviors that might be negatively, in fact, impacting someone's physical health, life stressors, stress that can be related from physical symptoms, crises, and chronic conditions. That's not all of them. That's just a few, but we wanted to remind everyone of that. We know that primary care is often seen as and has become the de facto mental health system. Primary care is when people go for whatever their needs are, including their mental health needs. So we want to make sure that we're equipping primary care with the resources they need to address those behavioral health issues. There are several types of integrated behavioral health, and there is a spectrum. We're not going to go across the whole spectrum, but we know, depending on the primary care clinic, depending on the resources they have, and depending on what resources are in their community, that their behavioral health program might look a little different. And this model, we fortunately are able to move to a high level of collaboration because we have students who are embedded right in the primary care clinics, and they're working hand in hand with the care team. Next slide. Okay, so with that, we don't want to spend too much time on what is behavioral health integration. We want to get down really into the heart of what's been happening for the past year. And so One of the things that we do is when we talk to students, um, and we've asked, what is behavioral health integration? Behavioral health integration is a fairly new model, and there's not a lot of opportunity for them to get training and education on that prior to them starting their internship. And so what we have done is we have developed a 2-day boot camp, and the 2-day boot camp really goes over the fundamentals of behavioral health integration and starts to help the students be aware of and build some skills that they're going to need when they move into the primary care setting. We talk about the different models of integration. We talk about referrals, how those are going to happen. Oftentimes in this model, there are warm handoffs. And so these are unscheduled patients who present to primary care and have an identified need. The students are then able to meet with them immediately, versus having to schedule an appointment and the patient come back. We talk to them about, we have Dr. Gibson talk to them about psychopharmacology. And really, she's able to give them education and information on medications they might hear when they're working in primary care settings. And this really helps them start to get familiar with medications, medical terms, and engaging with a medical provider. We talk to them about screening. How do we screen for patients? How do I identify patients? What tools are used? We introduce them to the most common screeners, the PHQ-9, the GAD-7, the Audit-C. We talk to them about risk assessment. Risk assessment's a big piece of what we do, because oftentimes we hear when we're using the PHQ-9, what if someone says yes to the last question, to question 9? What do we do? How are we going to manage that? And so we spend a lot of time talking to them about how to manage risk assessment. We prep them for, these are brief interventions. And so when we get that warm handoff, how do we manage a brief intervention in about 30 minutes? And so oftentimes that's not a way that we're traditionally taught how to practice. So that's another piece of this. Next slide. Okay, here's our wonderful students. You could see we have last year's cohort and we have this year's cohort. This is the second year of the program, and we are, you can see we've got some of our students here on Zoom with us. The first year we had 7 clinics who participated, and this year we currently have, 6 clinics. So I think it's really important that we talk a little bit about once the students go through boot camp and they kind of get these initial skills, how do we continue to support them? Because that's a critical piece. One of the things that I think is important is we quickly mention these clinics, most of them do not have mental health professionals who are on site working as behavioral health consultants. And so the students are really pioneers, and they are paving the way with what this should look like. And we provide weekly supervision, virtual supervision to the students. We help them grow their skills, guide their practice. We talk to them about specific cases. We talk to them if if their patient flow is not good. We talk to them about how to generate additional patient flows. And so we really spend a lot of time with them, helping them grow their skill and really develop the program. Some resources that we've provided for them are some education and resources, in an online webinar. We have worksheets, assessment tools, Anything that we're talking to them about supervision, we try to have in this online library that's accessible for them to use with their patients. Next slide. And now I'm gonna turn it over to Caitlin, and Caitlin's gonna talk to you a little bit about the data that we have found from the past 2 years of the project.
I'm sorry, my keyboard keeps sticking, so I keep trying to change the slide and it's not working.
No.
Yes. So one of the important things that we wanted to make sure came out of this program was not only the education for the students, but also are their interventions working? Are these patients being given the best care that they can? And I think that our data shows that these students have worked so hard. And I do want to remind everyone, these are year one. So these are last year students because we have a complete set for them. And then come May, we should have a complete set for these students that are joining us today. So to give you an idea of the population they're seeing, we wanted to go over the language and the payer source. And you can see over here that most of the patient or most of the students are seeing English speaking patients, but don't let that green fraction up there fool you. There is a lot more Spanish speaking patients than it looks like. A lot of our students are deployed to clinics that are in underserved areas where there may be undocumented patients that are coming through that speak primarily Spanish. A lot of them are seen at the UAMS clinic on 12th Street. I know Dr. Lofton's clinic down there has a very high, that county has a very high population of Spanish speaking folks. And then up in the Northwest Arkansas area too, there is a large Spanish speaking population. So these students are also getting exposure to different cultures and learning how to meet patients where they're at when they're speaking another language. And then the insurance payer source we thought was important to record because that would also give us some insight on the ages and the needs of patients coming in. I was a little surprised to see most of it was private because typically they're going to have those patients are going to have the most um, benefit from their insurance to be able to access mental health. But, you know, there's a lot of things that go into that stigma, time allowance, just maybe there's a high deductible. You know, there's a lot of things that go into not being able to access it. So a little surprised by that huge chunk of private. But the next one is uninsured, which we expected to see, accessing behavioral health consultant services in these clinics. And then Medicaid and Medicare kind of dueled it out there. I thought we would see more Medicare, but the Medicaid population coming in and accessing these services makes sense as well. To give you an idea of what kind of diagnoses these students are seeing, we wanted to break that down a little bit. And this pie chart on the left is going to be broken down on the next slide too. But what we saw in the first semester for these students is they were getting a lot of mental health referrals. And that's great. We want our social workers to have exposure to mental health referrals. But the whole point of this model is to see behavioral health. So both mental health and chronic conditions. So after the first semester of last year, we went back and we educated our clinics a little bit. We educated our students on how to advocate for themselves and their patients. And we were able to increase that behavioral health referral slot you see there a little bit more. And we're super proud of them. And that'll include your diabetes, your hypertension, CHF, COPD, tobacco cessation, weight management. And in addition to mental health. And then, of course, when you hear social worker, you hear resources. So they did get a lot of SDOH referrals, which is absolutely fine. We do want them to manage those. So we just thought keeping track of that was important as well. And then how are they getting their patients? Gold standard for behavioral health integration is warm handoffs. We really want the patient to be able to see the BHC that day and at least put a face to the name. However, that doesn't mean scheduled appointments where the clinic puts them on that BHC schedule before they meet isn't effective. It is effective, but what we were happy to see is most of the students are getting warm handoffs. It really just depends on what is most helpful for the clinic and the workflow they have. And then, like I said, this is broken down a little bit more. So the mental health diagnoses that were being seen, a lot of mood disorder, depression, adjustment disorder, bipolar, And then this came in second is anxiety, stress, and panic, which I was a little surprised at because typically anxiety likes to mask itself as different things, a heart attack, a stroke. I mean, there's like sends people to the ER all the time. So I thought maybe we'd see more of that, but still a large chunk of the referral diagnoses, and then chronic conditions like we talked about, and then miscellaneous. Now that looks like a large portion, but those were referrals that had to be added together that they just didn't see a whole lot of during year one, which was your attention deficits, dementia, possible autism symptoms. So those were kind of combined into one. Okay, so the big question on this is this working, right? We have all the data and we have all the student testimonies, but we want to make sure that these interventions are working, and they are. So with over here, you can see at the on the PHQ-9, the average starting out, and I'm doing this from memory, so forgive me because I didn't pull it up on my phone, is the average PHQ-9 was about 10.2 across the 400 patients for both semesters. And then after further review, the average ending PHQ-9 for these patients was about an 8.3, I believe it was, which is about 11% decrease. And we want to see that. That's a significant decrease for a population that size. And then the GAD-7, their typical starting place was about an 8.3. Typically, a trigger for a referral for anxiety on that GAD-7 is going to be about a 7 or above. So these patients were right above their trigger for a referral. And then the ending GAD-7 for the 2 semesters was I think about a 7.2, which is a 14% decrease. So we are really proud of these students from last year. I know we're going to see really good data from the students from this year as well, but we wanted to make sure that it's expressed that not only are these students getting really good education and learning how to be a part of the care team as they go through their education, but they're also doing really well in their interventions and learning very quickly how to do brief interventions. I'm gonna hand it back over to Kim. She is gonna talk with Dr. Lofton and have him share his experience with the students.
Thank you, Caitlin, and thank you for sharing those numbers with us. Okay, so this morning we have Dr. Lofton with us, and Dr. Lofton, he is a primary care physician. Dr. Lofton, I'm going to ask you just to talk a little bit about your clinic, population, and where you're located.
Sure. So we are located in DeQueen, Arkansas, which is southwest Arkansas, right next to the Oklahoma border. And I've been in practice 17 years. I just hired my first nurse practitioner, Shantae. You can see her in the picture next to me in the white coat about 2 years ago. And we have a large, Southwest Arkansas, or DeQueen specifically, has a large Latino population, and see a lot of Medicare patients, we do have a lot of insured because Tyson and Pilgrims are both big here. So a lot of our Latino patients work there and have insurance, but so do have some uninsured as well, and soon to start a MAT treatment for opioid use disorder. So that's something that because of ABN that I've moving into that realm slowly. But anyway, that's in a I guess demographic wise, that's who we are.
Okay, and I just have to say, Dr. Lofton, we are so excited to hear you say you're getting ready to start the MAT program. That's wonderful. Um, Let me ask, would you please share a little bit about your experience of what it's been like to have a student?
Yeah, this is our second year. Now it's really been a good experience overall. There's it's some well, I can share, two cases in particular. I can think of one last year and one this year that the students were able to help with intervention. Last year we had a student named Avis, and she was with us, and she was went in ahead of me. A lot of times, ideally, I guess my preference is when the patients are waiting to see me, if the student can go in ahead and do the PHQ-9 or GAD-7, then they can, alert me to say, hey, we've got a high score here. And whether I have to pivot and do a different meeting or it helps us to have a different conversation, that's been real helpful versus maybe getting a PHQ-9 or GAD-7 after I've seen the patient. And it's nice to have those ahead of time. But last year we had a patient that had I guess, really a controlling and verbally abusive caregiver, and that had never been brought up. But Avis was able to see this patient without the caregiver in the room, and one thing led to another, and the patient wanted to be out of the caregiver's home, and went to a nursing, like a skilled nursing facility. Unfortunately, that was temporary because the caregiver kind of basically made the patient feel bad enough that they went back home. But it highlighted, we had been seeing that patient for several years, and it had just never been brought up, primarily because the caregiver was always in the room. And without the student, without Avis in there, I don't believe we would have caught that. And, this wasn't a patient that was seeking help or showing even any signs of problems. And then just recently with Carly, we had a patient that wasn't, had some depression, anxiety. It actually just, we talked about it in the room and said the medicine we had them on last year just didn't make them feel good. And Carly went in the room, and this patient had probably one of the highest PHQ-9 scores. I think it was a 24, 22 or 24. Um, had suicidal thoughts. I'd asked the patient if she would be willing to, basically sign an agreement, a no harm agreement. And she said, well, I basically didn't give me an affirmative. And so we said, well, that's not, we don't like that. And so Carly was able to help coordinate getting her admitted to an inpatient facility that day. And we just saw the patient, I believe, on Monday. Her score was down below 10. So just within a couple weeks, got on new medicine. So that was an intervention that not only was Carly able to help, alert us to, but actually handle a lot of the phone calls, because that's a pretty time consuming process. And, for a staff, for a small clinic, you can see 7 people in scrubs, but one of those doesn't work for us anymore. So we have 6, and we're pretty busy. And so she was able to help handle and coordinate basically all that without my nurses having to do hardly anything. And that was a big help. But it's just nice having somebody that can either go in ahead of me, or that I can come out of a room and say, hey, would you go talk to this patient? Even if it's just doing a follow-up for their GAD-7 or PHQ-9, maybe they're currently stable. Just having someone who can go in and talk. And for me, honestly, some of these people, that's all they want to do is just somebody to talk with. And it actually cuts down on my time in the room, because they've already talked with Carly, and they're just ready to get their blood work and go. And they don't need me necessarily for the talk. And so it's been very helpful. I'm aiming to have somebody full time here, especially if we start our mat therapy. There's going to be a bigger need. But I'm very appreciative of, I believe, Blue Cross and whoever's been helping make this happen. We're very appreciative of that. So
Absolutely. Dr. Lofton, thank you. And thank you for recognizing Blue Cross. Without this endowment, this program wouldn't be possible. And so it's a pretty innovative program. And so we're very grateful to them for the endowment to make this possible. I have to say, it's so great to hear that one of my takeaways from your stories were the students are really essential in helping identify some of these patients that are really struggling, and it could be a life or death situation with as the story that you just described. And so the students able to help identify, alert that, work through a plan with you, and then it's really a time saving feature, it sounds like, for the clinic, because they're able to on-site coordinate a lot of the pieces, because a lot of pieces have to come together in order to get someone hospitalized and to try to manage that. And so, and a lot of times too, what happens to the patient while you're trying to get this coordinated, that could also sometimes be a challenge.
yeah, it's just in Southwest Arkansas, we don't have a lot of counseling services. And so, and there's stigma with going to a counselor versus being at the family clinic. And so it's just been beneficial for the patients and having someone to just to talk to. A lot of people, that's all they need is someone to talk to and somebody that can give some advice. And then for us at the clinic, it's helping identify people who might have slipped through the cracks. And otherwise, without that, and then just it has been a time saver, and it's definitely I think every clinic, I can't imagine a primary clinic not wanting to have this service. And there's a growing need. It's grown, especially since COVID. Anxiety and depression. And aside from that, we'll do weight loss counseling and soon to be some, interventions with patients that are, having opioid use disorder. So it's a growing need, and I can't imagine not having this as a part of what we're doing going forward.
That is wonderful. Thank you, Dr. Lofton. Thank you for sharing a little bit about your experiences and being a champion for the students and for this program. I want to make sure that, and we'll have more questions for you, but we also want to make sure that we ask the students some questions. And so we do have, I think, 6 students on with us this morning, and they're representing clinics from across Arkansas. We have 3 of the students in Northwest, a couple in the Central, and then, of course, 1 student placed with Dr. Lofton down in Sevier. So I think at this time, let's go ahead and Caitlin, we'll turn it over to you to ask the students some questions, and then follow back up.
Okay, if I'm going to go ahead and have the students introduce themselves so we can, so everyone can know where they're at, what their names are. I'm looking at my screen. I'm just going to go ahead. Laura, do you want to start? You're still muted, hun. There you go.
Okay, I just unmuted. I'm Laura Shirley. I'm at the UAMS 12th Street Clinic in Little Rock.
Thank you. Whoever wants to go next.
I'm Jack Brazier, and I'm with Mana Family Medicine in Springdale.
I'm Erica Sholkoff. I'm at North Hills Family Medical Center in North Little Rock.
I'm Molly Zeman. I'm at
Sorry, Molly.
You're great. I'm at Mana Family Medicine in South Fayetteville.
My name is Carly. I'm the student with Dr. Lofton in D Queen.
And then I know, I'm trying to make sure she's not on here. I know we have 1 more student who's not on here, Isabel. She's very sick this morning. So we told her to take care of herself and that we were sorry she couldn't join us. But her name is Isabel Peck, and she is also in the Northwest Arkansas area. Kim, can you remind me what clinic she's at?
Yes, and Isabel just put in the chat that she is at Fayetteville Diagnostic.
There she is. What a trooper.
Yes, and this is the first year for Fayetteville Diagnostic Clinic. So,
okay. Okay, so we wanted to, we give data, we give education on what the model is, what the students are doing, but we thought it was best for everyone to hear from the students themselves. So we've got some questions that we're hoping starts a conversation with them, but we're also going to have hopefully enough time for a Q&A from the audience if you guys would like to ask our students some questions. So to begin, we wanted to know initially what drew you to this model and to this internship, because it's a pretty specialized internship. It's different from what your other classmates are doing, and we were just wanting to know, like, what made you interested in trying out this new model, and what brought you to us. So anyone can start, and you guys can just kind of popcorn off of each other.
I can start. I, to be very honest, didn't know that integrated behavioral health was a field before hearing about this internship. And the internship coordinator at Euler mentioned it to me because on my internship application, one of the things that I mentioned is I'm really passionate due to my own experiences in navigating the healthcare system in whole patient care. And she was like, have you heard about this one? I think this might be perfect for you. And so the more I researched and looked into integrated behavioral health, it became very clear to me that this is something I'm very interested in. The idea that somebody can come into primary care and all of their needs can be attended to in one location. Certainly not a replacement for outpatient mental health therapy, but shortening the time between referral and being seen for some of these issues, especially some of the patients, with acute suicidality, was really important to me.
Thank you, Erica.
Yeah, for me, I didn't also know anything about integrated behavioral health. The University of Arkansas at Fayetteville just actually started a elective about it. And so my internship coordinator was like, I think you'd be good at this internship. I think you'd like it. And my previous experience was just in a nonprofit in Northwest Arkansas for my undergrad internship. So I was like, never really thought about even being a part of a medical group or field. So yeah, so I didn't know anything about it. My internship coordinator asked me if I wanted to do it, and I was like, sure. So I took the elective, and then we had the training that we talked about, and did not know what I was doing when I started, but really, really have enjoyed it and loved it. So.
I want to make sure I don't ever talk over anyone. So if you guys are fixing to talk, I'll be watching for you to come off mute. So those are both good points, Molly and Erica, that many people don't know that this is, many students, I should say, in graduate school programs don't know that this is an option. I didn't know it was an option, didn't even know I could do medical social work in any capacity when going through school. So it's kind of one of those things where it finds you when it should. And as we kind of spread the word about the model, hopefully it draws more people in and more students in. What I heard is it takes somebody passionate about this type of care delivery and really interested in that whole healthcare model, like Erica was saying, and then like Molly was saying, somebody just willing to try something new. And I think something that's really unique to all of these students is that they're all willing to ask for help. And I think that's a very important quality that you need to have in this setting, because like Kim has said, you don't have an on-site social worker. So knowing what your limit is and when to contact your remote supervisor is critical in this. And I think that just takes somebody who knows that it's okay to ask for help and when to ask for it. So thanks for sharing that. Looking at you guys going into your clinics, implementation, in my opinion, and probably others on the call, is probably one of the hardest part of this model, is going into clinics that may have not had you before, or maybe only had one or two before you, and implementing different workflows and your kind of your expertise within that care model. What can you guys share? What are some wins or maybe challenges that you experience, maybe initially integrating into the clinic, or kind of finding your fit in your space within that care team? What did that look like for you guys?
I think some challenges for me in the beginning were just figuring out the role and how long to meet with patients. Like we talk about it, of course, in the training, but when it gets down to it, okay, how long do I meet with them? It's very specific, integrated behavioral health and just being a behavioral health consultant, very specific. And it's not long-term counseling, right? It's short-term intervention. But naturally, when you're talking to people, even about short-term intervention, they're gonna want to share a lot of things, which is great. And that's a great part of this model. But finding the balance of how do I not turn this into long-term counseling, right? And just do short-term intervention was hard for me at first. And it takes a lot of guidance from the BHG for the client and just direction and speaking up front. Okay, this is kind of what this looks like if we're going to be meeting for about 6 weeks, depending on the case. And if you want more long-term after, I'll refer you out. So kind of finding that balance was hard for me at first. And then once I did, it was a win, and has been really cool to get to do that.
For me, the spontaneity of the whole thing was hard to get a grasp on at first, like because the ideal, as it was stated before, is that you do an intervention as soon as you meet somebody. And that was kind of challenging, especially when I was encountering issues I'd never dealt with before. Um, but I learned over time how to be more quick on my feet, and now I feel really confident about my ability to intervene ideally within the same meeting of meeting that patient for the first time and getting them what they need. So that was kind of a learning curve at first. I'll also say the medical jargon has been hard. It still is. I had no idea what A1C was when I first started working here, and I still don't really know what it is. I just know if it's too high, that's not a good thing. But so that continues to be a challenge, since that's not my educational background.
I apologize for disappearing briefly, but I think one of my biggest challenges is something I discussed a couple times with Kim. Was I was having like difficulties being assertive because obviously patients aren't just going to fall into your lap. Like you have to seek them out, see what the needs are. And so I've gotten a lot better at scrubbing the schedule, interacting with the nurses and the doctors more, and making sure that I'm treating or meeting with as many people as I can. But towards the beginning, that was a real struggle for me.
I think for me at the clinic that I'm at, I have a lot of Latino patients, and like it takes at least a good 30 minutes just for one patient just to get through the visit because there's a big language barrier there. I'm not fluent in Spanish, so I have to use an interpreter. And also, another challenge that comes up often is a lot of times they don't understand the depression screenings that I give them. And so I'll go in there and they'll score high on the screenings. But when I'm in there, they'll say, well, I think I misunderstood the questions. And so they don't necessarily score what's really going on with them. So that's been a pretty big challenge for me.
Yeah, I am very fortunate in that the clinic that I'm in is very bought into the idea of behavioral health. So that has really helped for me with being able to see patients, advocate with the doctors because they're all fully on board. The biggest challenge I had was kind of what Molly was saying was learning that brief model and how do you give people both the space to tell you their story and keep it within the 15-30 minute time constraints that we're often working in. And I think some of that has just come with time, like learning how to ask better questions so that we're not kind of opening up for a deep dive into a psychotherapeutic model. But being able to get down to the heart of like what the patient sees as their most pressing issue, I think has just come with time and experience.
So these are all really good points that you guys bring up, and a lot of them are very natural things that you'd find in any internship about like what Carly was saying of learning what intervention to use when. And with this model, you're just doing it at Alex said a faster rate than maybe some others because you're having to do an intervention the very first time you meet them and you have no idea what you're walking into. Some of the things that I heard help you overcome those challenges were using your resources appropriately. Like so, Jack was saying, learning how to advocate and increase assertiveness. Was something that he worked with Kim on pretty frequently. And then Laura, I know you and I have worked a couple of times on the fact that yes, your patients are not really understanding the PHQ-9. How do we make sure they are understanding it? And maybe we need to come off of the screener a little bit and have more of a dynamic conversation with them and meet them where they're at. So another thing I heard was just kind of finding your groove, and it just takes a little bit of time, a little bit of grace to find your stride in this setting. And then I thought was interesting that Molly brought up is educating the patients on how this model works too, because not only are you educating the medical team that you work with on how to use you and how you fit into it, but now these patients are being introduced to a new care team member, and they need to know how to utilize you too, and how the model works as well. So I thought that was an interesting point that you brought up, Molly. Okay, I would love to hear a little bit. I'm sure our listeners would like to hear too, on some patient examples. If you think back over the last 2 semesters to how you've seen your interventions work with these patients, and if any come to mind, we'd love for you to share how your intervention worked with them, what the changes were you saw, and maybe some things that you would do differently with the next patient, or things that you thought worked really well.
I can share the one. I apologize if you were at the NASW Arkansas. This is going to be the same patient example. But a patient that I saw last semester who presented to the clinic for an ER follow-up. And the reason she went to the ER was because she fainted due to really low blood sugar. I think it was in the low 50s. And when she came in for her follow-up visit, she also answered positively to question 9 of the PHQ-9, which deals with, any thoughts you'd be better off dead, thoughts of harming yourself in some way. And so the doctor referred the patient to me, and I was able to dig in a little bit more. She was having, some death ideation, but also having a lot of mental health struggles due to the breakdown of a 20-year relationship. She has several comorbid conditions, one of which is diabetes. Her A1C, I think, was 11.1. For those of you on the call, if you don't know, it should be ideally below 6. But we were able to dig in a little bit more, and she was experiencing a lot of binge behaviors and emotional eating to comfort herself, getting through this, as well as several periods of just not eating at all. And so her blood sugar was just having these really rapid swings. She's not a candidate for the semaglutide or Wegovy, any of those, due to a family history of thyroid cancer. So we met several times over the course of the fall. We were able to help her implement some more positive coping skills, work on CBT techniques of challenging negative thoughts. And by the end of our time together in December, I think her A1C was down 8 point something, it was below 9. Her PHQ-9 score had drastically decreased, was no longer having death ideation. She had started implementing setting alarms, reminders to eat, adding things like Lucerna into her diet to help her kind of stabilize her blood sugar. And she's doing a lot better. So I think, it was one of those really gratifying experiences of like, I can see very clearly how the intervention with her positively impacted both her physical and mental health.
I just kind of have a brief one, but there is a patient that I started meeting with recently, actually, who's having some, I'm not sure what the proper term would be, but like hypochondria-like symptoms, where she was dealing with severe anxiety. And a majority of the time that would express itself as anxiety surrounding like medical symptoms. So she would get like a pain in her side or like GI issues resulting from the anxiety, and then immediately schedule an appointment. And the PA who was seeing her told me that like over the course of like a month or maybe even 2, she was basically coming in like every week or every other week. And so I met with her just a couple of times, like I think it was like 2 or 3 times. And I focused on CBT techniques, like the automatic thought record and things like that. And just in that short amount of time, she actually was able to manage her symptoms just enough to stop scheduling appointments as consistently as she was. And so it was really cool to me to see kind of how quickly progress was made, and also just the impact on the care team, like that freed that slot open for other people that also need treatment.
Really good point, Jack, one of the things that we can do as behavioral health consultant is help with burnout of the care team as well. And when you have patients that come in and you don't have the tools to help them, and you there's nothing else that you can do for them, it creates a lot of burnout. So by you being in that office and being able to say, hey, I know that a lot of your symptoms are presenting this way, let's try a different intervention, and take some of that pressure off of the rest of the care team, crucial. I think that was so important there, in addition to the interventions you did with them. Erica, I think you brought up a good point there, being that, yes, diabetes and management of it is very important, but the fact that this person had just lost a spouse or a partner of 20 years, that was weighing way heavier on their brain than their diabetes was. And it wasn't something they could even see past that pain to deal with. And I think it's important to recognize that a lot of these patients have um, co-occurring life stressors that are affecting their chronic health, and why it's so important our BHCs are in these offices to say, hey, let's manage your chronic condition, but I also know you've got some life stress that's affecting it. And we know that stress is going to increase blood sugar anyways, right? Like we know that blood sugar level is going to increase because of stress, whether it's eating or just cortisol level going up. So being able to have that really crucial conversation of, as I see you, I hear you, here's some interventions to try and be able to bring down that blood sugar is critical too. Thank you for sharing those. I think, a little selfishly, I think those are my favorite part of the panel discussion, is hearing how you guys are really putting in the work there. I'm interested, I'm looking at time. I'm interested to know your time in this model and your experience with working with the medical team and within the medical model. How has that influenced your view on social work practice? And how do you think you'll take the concepts that you learned where the medical model and the mental health model intersect? How do you think you'll take that into your practice going forward?
I will hopefully be working at this clinic as a behavioral health consultant next year. And I think one of the things that's really just hammered home to me is how important it is to address all the different domains affecting someone's physical and mental health, and what their environment is. It's one of the things that drew me to social work initially, was the looking at the whole psychosocial environment that contributes to this patient. And I think the other thing for me is it's kind of hammered home the role of the social worker in advocating on behalf of these patients, both within the practice where they're being seen, to the other providers in the clinic, and then also being able to teach those patients how they can advocate for themselves in those same spaces going forward, because I can't follow them around to all their specialist office and do the same thing, but if I can help them learn how to navigate those better on behalf of themselves, I think it'll improve their overall health outcomes.
I definitely view health more holistically now, meaning that goes back to like the whole person, like everything that's going on with them. If I ever thought there was a barrier between mental and physical health, that's gone now. I don't think you can separate them. And I really think more people need to adopt this mentality of integrating the two, because one affects the other. And I really think regardless of what you're specializing in, I think it's important to consider both, because those are both equally affecting the person's life and they're influencing each other. So I think going forward, I will continue to have that holistic mentality and use that in my social work practice.
Well, I think it's important to note too, we're really excited about Erica, hopefully 95% sure staying in this model, which is something that we want to see come out of this internship. But what we want to see come out of this internship as well is well-educated social workers who are able to advocate. I think this model produces a lot of advocacy. So whatever route that you end up going, you all are going to know, whether it's direct practice or not, you all are going to know way better how the medical model works, and you'll be able to provide those skills to your patients and the people around you, because you'll know intimately about how much physical health and mental health intersect. And like Carly said, you can't really separate those things out. We've seen so many chronic care conditions improvement when you address the mental health factor in there as well. So it's a hard argument to escape sometimes. So um as always, we are, open to feedback as far as how this internship experience can be improved. If you're thinking back over the last 2 semesters, the education that you've got, the supervision that you've got, is there any areas that you wish you would have got more education in, or maybe had more exposure to, whatever it is? How can this experience be improved for the next batch of students that are coming up? You guys got to say something, or my ego is going to be very big today.
I mean, I do really feel that I was very well prepared. Just being honest. So kudos to you guys. But maybe a little bit more into, because referral is such a large portion of this model, maybe a little bit more, maybe not guidance, but training on how to help facilitate referral out. They see us for a few sessions, brief model. Hopefully we get them stabilized and then refer on to private mental health practice or community mental health center. And so really what that looks like and how we can best set the patients up for success with that. Certainly learned it as we went along, but maybe a little more of that on the front end.
Maybe maybe a little more training on working with families. Because for those who don't know, that's a competency that social work students have to meet. We have specific assignment, like we have a portfolio and everything. We have to do like a family assessment and intervention. And I would definitely appreciate like some more information on how to intervene with families, because it's really different than intervening with just an individual.
Oh, yeah.
Because when other people are in the room, you have less control over the conversation, I feel, and you don't really know where to turn your focus to, but you want everyone to feel equally included. So maybe that's an idea. Some more focus on how to intervene with more than one person at a time, especially in a family system.
And I just have to say, Carly, that's such a great point because oftentimes in primary care, it's not just the patient who is coming in, and it's not just the patient who's there in the room. And so how do you address that everyone in there in that system?
Good point. And to Erica's point too, is learning how to network. That does not necessarily come natural to everyone. And when you're trying to learn a new model and go through school, and then also trying to, reach out to your future colleagues out there to figure out who does what best and how referrals fit into this model, I think that is a very good point too, Erica. Okay. We do want to save time for questions. If anyone has any questions for the students or for us, we'd be happy to answer them. So we're going to open it up for the next 5 minutes or so to allow for Q&A. And you're welcome to come off mute, or you're welcome to put it in the chat, whichever is easiest.
As you guys are getting ready for your questions, I want to make sure and thank um, the people who made this possible. We wouldn't be here today if Blue Cross Blue Shield didn't make this opportunity possible. So thank you, Blue Cross Blue Shield, for the endowment that you made to the universities. We also want to thank the University of Arkansas at Fayetteville and the University of Arkansas at Little Rock, the MSW programs for thinking this was a good idea, that an integrated behavioral health internship is needed and would be beneficial. One of the things that we hear as we're talking about integrated behavioral health and as we're working with different primary care practices across the state is there really is limited resources and there's a workforce shortage. So with that, so we're hoping that this internship provides some additional behavioral health consultants who are going to be out there. So for clinics that are listening, please know these students will be graduating in May and they'll all be looking for jobs. We also want to thank our primary care clinics for being pioneers in this project with us, supporting the students and being willing, because we know doing something new, it can be challenging. It can take time and it takes your energy. And so thank you. We want to thank Dr. Lofton and Lofton Family Clinic. We want to thank Manna. There are 3 Manna clinics. We had Manna West End, Manna South, and Fayetteville Diagnostic Clinic, and North Hills Family Medical Center, as well as UAMS 12th Street Clinic. Thank you. With that, I'm going to pause and get questions, but wanted to make sure we gave our thank you before we ran out of time. We have 5 minutes if anyone has a burning question they'd like to ask.
Are you able to see that question? Because that is a Kim question.
Yes, yes. All right. Well, thank you for the question. The question in the chat is, I might have missed this information earlier, but for those that are hired as a BHC, how is this billed to insurances? And so first, let me say that the student services are not billed. And so that gives us a little bit of flexibility. But you're right. Once clinics have an opportunity to have a behavioral health consultant in their clinic and they decide we really want to do this, how do we bill for this? There are different billing codes that are out there and available. There are individual psychotherapy codes that can be billed. Those are 90832 codes all the way up to the 90384 codes. Those services are billed in 15-minute increments. There's also health and behavior codes. And it also depends on what type of insurance you're trying to bill. Are you billing? What type of contracts do you have? What does your reimbursement look like? So it starts to become really involved really quickly. But yes, there are codes that are out there and available. And probably the easiest codes to start off billing with for this are those individual psychotherapy codes, which are the 90832, 90834 codes. I also have to give a shout out as far as billing and coding. On the CMS website, they have a really nice behavioral health integration booklet with guidance for all available codes that are billable and a description. Other questions? If we don't have other questions, I have a question for the students. Just knowing now what you've had to go through, I guess it's been, about 8 months or so. Would you do this internship again?
I would say yes, absolutely. I have learned so much and never ever thought that I would be doing medical type social work. Just like I said earlier, always thought that I would be doing nonprofit. So, yeah, I would say I would definitely do it again because I've just gotten such a greater perspective of possibilities as a social worker, but also what it looks like to be on an interdisciplinary team.
Yes, for all the reasons Molly said.
Awesome. Woohoo! Okay, we know it is at the top of the hour. We are going to be offering CMEs for these monthly webinars. So please know that. And please fill out the evaluation form. I just have to say again, thank you, not only to Blue Cross for making this possible, the clinics for hosting the students, but to you students for all of your work this past year. This is really hard work. As we heard you talk about, you didn't know what you were walking into. It's been a huge learning curve. You've learned a different language. And you really are the trailblazers. I mean, when we talk about grit, I think you develop a lot of grit in this type of internship because you're learning how to work on an interdisciplinary care team and you're learning all the different pieces. There's lots of moving pieces. It's really fast paced, and you guys are doing a phenomenal job. And patients are getting better, and your communities are using you as wonderful resources. So please know that you're changing lives every day, and you're going to go out into the world, and you're making huge changes. So thank you for what you're doing, and thank you for all your hard work. All right. With that, we will see you all. We will not be having a webinar in April because we will be having a full day behavioral health integration conference. So if you've not heard about that or signed up, please go to our website, www.abennetwork.org, and we will be there. We will be in Little Rock at the St. Vincent Center for Education for a full day of behavioral health integration, and we'll see you back here in May.